for that introduction received too generous, and wanted to thank Rich for inviting me. Rich said to me last night he's worried that Mitch Berger, my boss, is going to be upset because I've preceded him up here for grand rounds, but Dr. Berger did spend a number of years here before, obviously went to UCSF, and there's a number of the faculty here that I know and from meetings and recognize. I think Randy Chestnut actually used to work at our place. I didn't see him much because he did trauma and traveled a lot, but a number of people here that I know well. It's just the good thing about neurosurgery, it's a small community. It's my disclosure slide, and some of the things were listed as the objectives on the poster out there are really things I'm going to discuss with the residents later today, some of the technical aspects of surgery, and not to be presented here, but I thought I'd go through some historical perspective. I'll watch my time, and if I don't make it through my slides, I'll speed through the last few, but this is a little bit about who I am. My parents were Irish immigrants that took the boat separately to Toronto. They met in the Irish community. I was born, raised, Toronto, did everything, high school, medical school, undergrad. I went to British Columbia, went to Vancouver to do my residency. I had a girlfriend at the time who was an intern in Vancouver, so that's why I went there. She dumped me before I got there. But then I wanted to stay in Vancouver and do neuro, and they wanted me to do gliomas. So I looked around for neuro-oncology fellowship. That's how I got to UCSF the first time. And I went back to Vancouver, worked at the University of British Columbia, and then Dr. Wilson called me one day. And I decided to go back. And when I crossed the border in Bellingham, in those days we had a visa called an I-94 TC visa. And the guy said to me, he said, "So you coming down to chase the almighty dollar?" And I said, "Well, actually I'm taking a $50,000 pay cut." And he said, "In that case, welcome." It was all about timing, and once I came back to UCSF, actually weren't that many of us working at Moffitt Hospital. Just a small number of us. You can imagine just these guys and me. There weren't very many of us. And then when Mitch came in '97, I never had any undergraduate training in research. I only did 2 years of undergrad before I went to medical school. And Mitch was big on wanting everybody to do research. And I did it, but I picked meningiomas because even though it was seemingly a surgically treatable problem primarily, the tumors did recur, and I didn't want to do glioma work because it was too competitive and I didn't have the training, and it was really a full-time job. And Phil Gooten was my mentor during the second year of my neuro-oncology fellowship, and I did a lot of brachytherapy with him, and one of my secondary interests is radiosurgery. It's about 25% of my practice, and I actually really enjoy the radiobiology. Yesterday, I flew up to Seattle and then down to Pasco to go to the IsoRay factory. They make cesium-131 radioactive implants, which we use for brachytherapy for large or primary or recurrent brain metastases, and also use it for recurrent atypical malignant angiomas. So it was kind of cool to see that technology there. This is kind of what my clinical practice looked like a couple of years ago. So about 33% of the case of radiosurgery, which all happens down in the basement. And my practice has kind of shifted, I think partly because of Mitch arriving towards meningiomas, but Dr. Shaker knows that I was trained quite well in skull-based techniques by my professor from Vancouver, who took, as the chairman, self-funded sabbaticals to go work in Pittsburgh with Dr. Shaker. He went to Ljubljana, Doling for a month. So he came back and taught me all those things. And when I first started at UCSF, everything was pterional or retrosigmoid craniotomies, and I was doing some of the other things, bifrontal, extended frontal orbital mag. They hadn't seen that, so I got written up by one of the more senior nurses for unusually aggressive surgical procedures in the first 6 months, and had to go and answer as to why I was doing this. Anyway, it's been a lot of fun since I've been there, and I haven't moved for primarily family reasons. I don't have any family in the United States. I didn't want to disrupt things for my wife and kids, just to, pull up and move out when they establish their family. So this residents pulled this up for me, Rajiv. This is number of meningioma cases. You can believe it, since 2000. So it's busy, and it's been a focus. We don't operate on everybody. Obviously, we usually follow the patients from the clinic. If they don't have any symptoms, we do nothing until there's documented growth, or they develop symptoms specific to the tumor site. But it's really been an enjoyable time in my surgical practice there. Today, I'm not going to talk, I'm not a researcher, but I do collaborate with people in lab. Money that donors give me, I give out to them for requests for applications for pilot studies, which helps them get the preliminary data which they need in order to apply for bigger grants, and that's worked out quite well. And I'm going to discuss primarily some clinical things, and then I'm going to talk about the risks of reoperation and shake yield. The motivation for this was Sam. Operate. And that's the treatment for meningioma. Was one of our senior colleagues, and I was saying last night to the resident, I think there's finally a paradigm shift. That people are moving on their careers, other people are coming up, and realizing that surgery alone for meningiomas is not curative, and it might not be the best treatment, either in a primary form or when the tumor recurs. So let's talk a little bit about these are some of the research papers that we put out from lab. We were actually one of only 2 laboratories focused on meningioma research for a number of years. Our person who led the lab, Anita Lal, actually left to go to industry. She went to Genentech, so we lost that person. So now I collaborate with other individuals in the Brain Tumor Research Center, and we produce some reasonable information about meningiomas. This is the most recent paper, which is a very intense molecular biology effort by this radiation oncologist, who's a really smart PhD and spent a lot of time doing research, and he knows all the techniques, and I think he's going to be very successful. So this is one of the people that I help support. And here's an example of some of the work that he's done with 299 meningiomas. He calls it meningiomics, meaning molecular biology of meningiomas. And we've had the ability, because of the money we've been given, to do a lot of these studies, and he's funded, but this is his most recent paper on comprehensive molecular profiling, and the paper is actually quite long and contains a lot of information, but you can see here, as you would expect, for example, as the meningioma grade rises from benign grade 1 through 3, the number of somatic mutations increases, and the mutation burden obviously has an influence on outcome. That's pretty straightforward, and he's looked more closely at different molecular markers that may be related to meningioma pathogenesis. We've done some other things, like looking at intraoperatively at spatially targeted samples to see if there's heterogeneity in meningiomas like there is in gliomas, and maybe that's one of the reasons why the tumors tend to be recurrent or resistant. The bigger tumors like this tend to be atypical, right? And then I'll speak to that later. Are they called atypical because they're large and the microenvironment is perturbed centrally, or are they large because they were atypical to begin with, therefore they grew more quickly? And it's kind of a chicken and egg question, but I don't know that we actually understand, but we did look at that, some of the information. And we have other studies that we're planning to continue. And I was telling Rich last night that I This family, this lady, Linda Wolf, died of complications after surgery for a bifrontal malignant meningioma. She suffered venous infarct. She developed a coagulopathy related to the pneumococcal vaccine she was given before admission by her primary doctor to protect her from postoperative pneumonia. Her husband, who's down here, Bruce, sponsored a lectureship, and the most recent lecturer this year was your faculty person, Lalagum, and other people in the past. And the Wolf family just recently, Mr. Wolf passed, was quite wealthy and left $4.5 million for meningioma research and work. So next Thursday we're going to celebrate a new chair in meningioma surgery. And I'm going to transfer my Robert and Ruth Halpern chair to David Raleigh in the lab, because he has a co-appointment in our department. So David will have some additional funds to assist with his work and hire postdocs. And then we have a 5-year plan to roll out kind of an internal program project of meningiomas, and hopefully within the first 3 years develop some new information that will be suitable as pilot information for the researchers to submit their own R01 grants. So we plan to spend, the university takes 10% off the top, and our plan is to spend the rest of it in the next 5 years on research, and that's what it's intended for. So it's a great opportunity for us. So, glioblastoma is not the most common primary brain tumor. Gliomas are as a group, but if you look at one diagnostic entity, it's meningioma that's the most common tumor from the age of 35 till death. And if you look at the statistics for Washington State, based on your state population of 7 million, you should get, there's probably 1,500 different benign tumors per year, and the most common benign tumor amongst that group is meningioma. So there's a large new cohort of patients that need management and treatment. And because most of the tumors are benign, after the patients are initially treated, they live for a number of years. So the total cohort of patients that you follow with this diagnostic entity actually increases over time. And so I've got about 1,400 people that I've been following over the years, and it's it actually tends to be a big effort, and I need help. So with these patients, when they come to us, they they may not have any symptoms. Their meningioma may be discovered after a car accident, concussion, get a CT scan. And the papers on the natural history of meningiomas are relatively short in terms of follow-up. This was one of our papers from UCSF. Average follow-up is only 4.6 years. And for a condition where the patients live 25, 50 years after diagnosis, this is relatively short. So it doesn't really help us that much with our understanding of what happens to the meningioma if it's just left untreated and observed. I take into account the patient's life expectancy when I'm making decisions about whether they should have treatment or not. The longer you live, the longer you're expected to live. So when you're born, if you're male, you're supposed to live to 76, but if you're 80, you're expected to live to 90. If you're 90, you're expected to live to 94. So some of these things I take into account when I'm recommending treatment or not, or observation for the patients. And I think it's important to do that. So if I've got somebody who's 30 years old, like in this paper from Sweden, where they followed patients for 25 years, number one, with that life risk exposure, the tumor's going to grow for sure. Number two, even if I treat it and follow up, I have to make sure that I follow the patient continually. So in this paper from T. Matheson, for parasagittal meningiomas, the recurrence rate was 50% at 25 years after diagnosis and after treatment. And all the patients didn't live that total 25 years. Half died from other causes and half died from either meningioma or the treatment for it. So this is a kind of lifelong condition. And unfortunately, like for glioma patients, of course, they don't live this long. So the meningioma patients are are particularly a challenge to keep them in the medical system, make sure they do their follow-up, as opposed to coming back 6 years later with a tumor that was just as big as when they first started, which is a real shame. The surgery for meningiomas hasn't changed. I mean, there's adjuncts for surgery. Surgical techniques have changed, but it's still very difficult to get a good result all the time for these difficult tumors, and that's what Cushing said back in 1937. And one of the things that we decided to look at in the perioperative period around the treatment of our patients was whether or not they should get prophylactic anticonvulsants. Rajiv, this paper won the CNS Tumor Paper of the Year Award. One of our medical students helped put together, and Steve McGill. So it's going to be plenary session talk at an upcoming meeting. But what we did was we wanted to look at whether or not, whether anticonvulsants were necessary or effective. We had a large number of patients, 1,033. The bottom line was interesting in that here are some of the factors associated with an increased likelihood of preoperative seizures. Some of the things that clinicians know: peritumoral edema, parasagittal vault location, and then this is the multivariate analysis of postoperative seizure likelihood. So again, the vault location as opposed to skull base, any medical complication, if you had a pre-op seizure, if you had a post-op in-hospital seizure, these all increased your risk of postoperative seizures on a long-term basis. So here's the likelihood of the probability of a seizure after treatment. And the red is for those patients that had preoperative seizures, and the blue is for those patients that never had a preoperative seizure. So you can see, even if you didn't have a preoperative seizure as one of your presenting features, you still have an ongoing but small risk, and it's much different than the patients who had preoperative seizures. The interesting thing was that the long-term results for seizure control in the patients, Dr. Ojem would be interested in this, long-term seizure rate in patients who had preoperative seizures is worse than the long-term seizure control rate than temporal lobectomy for non-lesional medial temporal lobe sclerosis. So if you do a temporal lobectomy, seizure control rate, what should it be? 70, 75%?
Well, that's why that 10 to 25 year thing is so important. It's actually less than 50%.
Is it? Okay.
In the long term. Yeah, 1 year would be
74.
with lesion 75.
Yeah, and ours was 68%. So we thought that it was important. Postoperative seizures in hospital were more likely to have neurologic deficit if you had a vault location. Late postoperative seizures were related to whether you had a preoperative seizure at all and whether you had a big tumor. And this actually changed the likelihood of long-term seizure risk if you had a preoperative seizure. Actually changed our practice. So if a meningioma patient has more than 3 seizures before they see us, before we take them to surgery, then we will take out the meningioma and then do electrocorticography to see whether or not there's an underlying seizure focus in the brain adjacent to the tumor. And if there is, our epilepsy surgeon, Eddie Chang, comes in and deals with it as he sees fit. So it'll take a long time to find out whether or not that's a benefit, but a 68% seizure control rate is not very good for removing a meningioma long term. So as a result of that seizure study, we're actually planning a multi-center trial of perioperative anticonvulsants in patients undergoing meningioma surgery. So they'll either get Keppra or placebo, and the early endpoint will be 3-month seizure freedom. All right, let's move on to another topic, and that's tuberculum celli meningiomas. For maybe some of the younger residents or medical students that don't know, that one of the controversies in our specialty now is whether or not these are tumors that occur about 5 centimeters back from the crista galli. They occur right between the optic nerves. Patients usually present with visual deficit, and in the surgical specialty, the debate is, can you take these out with an endoscopic into nasal transsphenoidal approach, or should you still be doing a transcranial operation? And so I arbitrarily came up with some classification system. Dr. Shaker's published a more detailed, complicated 8-point grading scale, which actually didn't turn out to be predictive. Correct, Shake?
No, it was.
Was it in oral neurosurgery?
You asked that question.
Yeah. So,
But it needs a larger series. So.
yeah. So anyway, I came up. This is a less detailed, simpler thing, and it's totally arbitrary. I got beaten up on the reviews after submission for trying to get it published. But it was really related to the one of the critical anatomic features, which is the interoptic canal distance, which is about 12 to 15 millimeters. I took other relationships, such as the relationships with the optic canal, because once the tumor infiltrates the optic canal, it requires a different surgical maneuver to try and make sure you get that out. And if it's on both sides, it's more difficult because you got to drill both optic canals. And then the arterial relationships are important. If it's just abutting the artery, it's one thing. If it's enveloping it, it's another. But if it's completely surrounding it, it's even more difficult. So I thought those might be, from my own surgical experience, risk factors that might be able to predict which patients would be better suited to an endoscopic into nasal versus transcranial approach. We cooperated initially with the group in Naples, which were the first surgeons to report the endoscopic into nasal approach. They've stopped doing it, by the way, because of the recurrence rate. So they've reverted back to transcranial, but we did the initial study with them and used this scoring system. So the tumor size was either 1 or 2, depending on its diameter. And then you got scores for optic canal invasion, whether there was none, one side or both, and then arterial encasement related to the relationships. So here's the tumor scoring based on tumor size in the region of the tuberculum. These are the canal scores, none, one canal or both. And then these are this is the important thing about the relationship to the optic canal. It's usually down the medial aspect at the junction of the chiasmatic sulcus and the optic canal. And I do a big, I changed my approach a little bit, but I usually do a subfrontal approach for the bigger ones, and I can drill off the roof of the optic canal and frequently get out these little tiny bits of tumor, which you can see here on the coronal MRs. This is tumor tons extending down the canal. If you don't get that out, that's a residual tumor, which will lead to an increased likelihood of recurrence. These are the arterial relationship scores. So if it's just abutting it, enveloping it, or surrounding it, increasing degrees of difficulty for surgical resection. There were 104 patients from UCSF, 35 from Italy. Follow-up, as you see listed here. Most of the patients were operated transcranial because the tumors tend to be bigger. The difficulty is the small tumors that are perfect for endoscopic and nasal, the patients usually don't have any symptoms. I mean, they might have headache, but they don't have any visual complaints. And so it's a little bit difficult. Most of the tumors that are symptomatic are larger, therefore they're more difficult, and we tended to operate on them more often transcranially than not. You can see that here is these unusually aggressive surgical procedures I was doing for these cases, which I think worked out well. Patients had good result. The cosmetic results were very good. And then some of the other patients had standard pterional simple operations for removal. So as you would expect, and as I alluded to, the smaller tumors tend to get done into nasal. And this information here proves that the higher the total tumor score related to size, canal, arterial relationships, they tend to get operated on with a transcranial approach, as you'd expect. And you can see that there's a bigger cluster of smaller, simpler tumors for the endoscopic into nasal, which is appropriate, maybe, right? Maybe we shouldn't be doing these ones endoscopically, and maybe we shouldn't be doing these ones down here transcranially. So I think it might be reasonable. Thankfully, whether you did it endoscopically or transcranially, only about 11% of the patients had worsening of their vision, which is one of the primary symptoms. So we at least were helping them. About half the patients had improvement in their visual status. So here's visual outcomes by surgical approach.
Okay, I'll be over.
And blue is better, red is worse. The biggest tumors get operated transcranially are the toughest ones to dissect off the optic apparatus, and therefore you expect that they're more likely to have complications. So that's kind of what you expect. The best tumors, the tiniest ones, no optic canal invasion, and sitting right in the middle, visual outcomes are great because they're not actually impinging on the optic apparatus, so it should be fine, and that's what the information shows. Now, risk factors for worse outcome are primarily related to tumor size. The bigger they are, the more they stretch the chiasm and the optic nerves, and as you'd expect, the greater the likelihood of a worse visual outcome. If you take all tuberculum cellular meningiomas, and you look at the tumor score here, so this is a small one, this is a bigger one, then the likelihood of the vision being the same if the is 84%, and for the small ones, the likelihood of vision being the same is basically 100%. We can't remove these tumors completely all the time because the location's hard to remove the dura in the region of the optic canal. So you can see here that gross total resection is only achieved in 65% of the patients, which is actually a surprisingly low number. And here's extent of resection outcomes, and as you'd expect, the higher the score, the greater the likelihood of a subtotal removal. And you can see here that the smallest tumors right in the middle again that can be operated transsphenoidal are the ones that are most likely to be removed completely. In terms of extent of resection outcomes, as you'd predict, the more canal involvement is, the less likely you are to remove the thing completely. So that was the main contributing factor here was canal score, and then total score I think usually relates to other factors such as the arterial relationships and tumor size. So I think I'm coming to the end of this. Skip that. There was a 10% rate of recurrence in the follow-up period. As I mentioned, the Italians have stopped doing this transsphenoidally because they feel that there's a higher recurrence rate than when you operate the transcranially. Overall, the complication rates were the same between the transcranial and transsphenoidal group, but they were slightly different in their distribution. And as you'd expect, the CSF leak rate was higher in the transsphenoidal as compared to the transcranial group, and not a big surprise. So the summary from this effort was that the patients actually did pretty well. As you can see here, 82% of the patients had better or stable vision. There was a 10% recurrence rate. The overall complication rate was 14%. And I wasn't trying to say with the study that, transcranial route's better than endoscopic and nasal or vice versa. I was trying to see whether or not the scoring system would help the surgeons pick the most suitable approach up front. So we're about to send a letter to your center's going to get one. A number of the teaching centers in North America, Seoul, Korea, Japan, England, Ireland, Italy, France, and Turkey. And we're going to do a study, so hopefully we'll have like over 1,000 tuberculum cellular meningiomas. We'll have better data, bigger numbers, and that'll be a multi-center trial. And one of a postgraduate student is going to work, that's going to be one of her jobs, is to help coordinate the intake of all this information over the next year and then do the data analysis subsequently. All right, what about hyperostosing sphenoid wing meningiomas? This is just submitted for, no, it's not submitted for publication yet, but I was surprised to learn that there aren't actually very many publications on the topic. Lots of book chapters, but hardly anything in peer-reviewed literature. So on sphenoid wing, there's usually 3 locations: medial, middle, and lateral. two types of meningiomas that occur, globular, the round ones, and then another type called hyperostosing. So here's a globular round sphenoid wing meningioma, and here's a young lady with bilateral hyperostosing sphenoid wing meningioma. It's a little plaque of tumor, and most of the involvement is in the bone. Okay? So all this black stuff is called hyperostotic bone. And if you decalcify the bone, you'll see meningioma cells growing inside the eversion canals. So unless you remove all the bone, you're not removing all the tumor. One of the challenges for us is to get is to try and remove as much bone as possible, do it safely, and then remove the soft tissue component, which is usually in the posterolateral orbit, and then over the sphenoid wing here in the middle fossa, and get a good result, primarily with respect to vision and cosmetics. Now, the interesting thing is that this tumor is almost always seen in women as compared to men. Normally, for intracranial meningiomas, there's a 2-to-1 female-to-male relationship between the incidence of meningioma. In the spine, it's 20-to-1. So if you had all spinal meningiomas, there's 20 more women with spinal meningiomas than there is for one male. And for this particular tumor type, in the original description by Cushing, they were all women. They all had unilateral, painless proptosis with lid swelling and temporal fullness. And the proptosis was the first symptom in 9 of these 19 patients, and the temporal fullness was the first symptom in 1 of the 19 patients. He operated on 16 of the patients. This is a collection of photographs of 12 of those 16 patients, and he described all the clinical symptoms in this 1937 book publication. So the indications for treating these patients, because they'll come to you with an eye bulging out, and it's either documented growth on objectively on imaging of the soft tissue component or the bony component, which is less likely. Progressive proptosis, so the patient's eye keeps, they look back at pictures from family events and they can see that their eyes sticking out, or somebody, a family member hasn't seen them for a long time, comes and meets them and they say, "Oh my God, what's the matter with your eye?" And rarely does the proptosis get so bad that it's a corneal exposure problem, meaning the eyes bulging out so much the patient can't close their eyelids, so their cornea is getting dry. But if they have a component of tumor in the orbit, they'll actually get compression of the optic nerve, and a lot of the patients later on in their illness will get visual loss. And they all have some kind of periorbital pain syndrome. So here's a couple of examples. This lady was actually 79 years old, and by the time she got to us, she had light perception only in the right eye, but you can see here this fuzzy looking bone. That's tumor in the bone, so-called hyperostosis. There's just a little thin plaque of meningioma here, but the problem is this intraorbital component. You can see here's the optic nerve, and at the orbital apex, she's got a compressive and ischemic optic neuropathy and that was the etiology for visual loss. She had cataract replacement, didn't make any difference, no surprise. And then surgically, you can take out a lot of the bone from the foramen ovale, rotundum anteriorly, above and below the speroorbital fissure, roof of the orbit, convexity bone, etc. And we reconstructed something like this. And this is what the post-op result looks like. You can see that even with the assistance of the ophthalmic surgeons, oculoplastic surgeons, when the tumor is within the periorbit and speroorbital fissure, they can't get it out for fear of creating muscle weakness and disturbance of eye movements that they'll leave behind. So this patient needed subsequent radiation therapy. This is the picture of that young woman with the bilateral tumors, and she had significant proptosis on the right, and then we operated. This is the target is primarily all this bone. And again, this is what the post-op looks like. You can see all the bone has been removed. We routinely reconstruct the orbit. I'll probably talk about that a little bit with the residents, but what our protocol is. And so because this patient has bilateral disease and she's got good vision, we're just following her. We're not going to radiate her at this point. So the surgical technique for removing these tumors is usually a joint effort. So like many vestibular schwannomas where we operate with neurology, I always operate with my ophthalmic surgeon, oculoplastics. From the neurosurgical perspective, there's advantages pre, inter, and post-op. They do the preoperative assessment, they can measure the proptosis, they can evaluate the patient's vision, they do Humphrey visual fields. Intraoperatively, they assist with the removal of the tumor in the periorbita and the orbital component, help with the reconstruction of the orbit, and then they follow the patients. All the patients have mechanical disturbance of eye movement for a period of time, so it's to the surgeon's advantage to be able to have somebody co-following them at the same time. And their contribution to the operation is about an hour. And the other 6 or 7 hours is all neurosurgery. We usually use a coronal scalp incision, the skull-based approach. Remove the bone first, and then we remove the convexity-dermal graft of the pericranium, and then we do the orbital reconstruction. And after we're finished with the orbital reconstruction, what we're doing is we pull the scalp flap up, we check the position of both eyes. So we open the eyelids and look at the position of the eye, make sure that one is, the operated side is not still proptotic, or more importantly, that it's not inophthalmic, meaning it's not sunken down. Because if the eye is sunken back, you'll never be able to correct their double vision. And I think that's an important thing, because when you remove all that lateral bone, all the lateral wall of the orbit, that's when the eye can sink back and you're excising the periorbita, the fat just kind of falls apart. And then what we do is we do something called a forced Seduction Test. The ophthalmologist will open the affected eye, grab the tendon for the muscle inserts in the medial lateral rectus, and push the eye back and forth to make sure that it's not caught on the implant graft. And we actually did have, we've had 2 of those cases where we didn't do the forced Seduction Test intraoperatively, and now because of that, we always do it. So we make sure that the muscles are not entrapped before we close, so we don't have to come back later with another procedure. Anyway, when I was up in Vancouver, I wrote, this is actually the believe it or not, Shake, this is the first, I didn't know this, my ophthalmic surgeon told me this was the first neurosurgical paper, not a chapter in a textbook, about technique for doing this. We only had 8 patients at that time. We had some optic nerve pathologies we also operated on. And this is, well, I don't know if I have internet access.
They're guest access.
Huh?
You can just, there's a guest access.
Is there? Yeah, let me just see if I can do it, because this is kind of cool.
Right there, just go there again. Just put University of Washington patients and visitors.
So one of the people that works in our department is foreign trained neurosurgeon who's working in, his focus is anatomy, but he is able to, so I have to sign in.
Chris, can you help?
Huh?
Chris.
Hang on, we'll get you help.
Yeah, patients in there.
Which one?
I think you're on the UW6.
Yeah, just, Chris, what did you do it for?
It's okay. But the nice thing was, what I did was I took my skull home from the office, and I ordered watercolors from Amazon, and I painted the skull components green. Here, that I thought you could remove safely surgically, and then the red, I painted those components of the skull red that I thought you could remove. So So, this is the model, and then, it's not showing. Oh. So then, the green parts are points of bone which you can remove surgically and reconstruct. I don't take off the suborbital margin. It's really hard to do it cosmetically to reconstruct it. And then if you look at the bottom, skull base, we don't take out the temporomandibular joint. And then everything that's lateral to the foraminal valley and spinosum, we can take out. All the bone of the lateral orbit here can be removed. So if I swing around here, number 2 is the optic canal, which you can remove all of this lateral wall and remove the roof close to the ethmoid sinuses. Don't want to get in there. And then you can reconstruct this and actually get a fairly good result. So I'll get back now to that. Example of a patient with this proptotic eye and the bony changes. And so this is the kind of scalp incision that we would use. Back in the day, if we thought we needed to get proximal control for the carotid, we would extend the incision down. This is what Shaker reported in his early work back in the late 80s, actually. And then I do a 2-part orthozygomatic thing. It's easier for me, mid-body zygoma. And the reason for taking down the arch of zygoma is it lets the temporalis muscle fall away, so you can remove all the bone of the floor, the middle fossa greater sphenoid wing to rotundum, to the spinosum ovale and rotundum, and all the bone around the orbit. If the vault is not, cranial vault is not involved by tumor, you can actually split the calvarium and use that to reconstruct the orbit. So here's an example intraoperatively of doing that, splitting the calvarium. Here's the roof and lateral wall. And this is a cosmetic result for a patient. The tumor was on the right-hand side, so her eye was very proptotic at the beginning, and a good result. So we looked at more recent series between 99 and 2017, and then we also measured the so-called Proptosis Index. So only 56 patients, and this is the distribution of presenting symptoms. You can see 71% of them had proptosis. Extended removal was subtotal in the majority of cases because of involvement of bone medial to those structures I talked about. Visions improved or unchanged in 98% of the patients. And there was a 25% local recurrence rate. The mean time to recurrence was about 3 years after surgery. And this is the so-called Proptosis Index that Bill Caldwell from Utah has used. And what he does is measures from the optic chiasm to the back of the globe on the affected and unaffected side. The numerator is the affected side, the denominator is the unaffected side. So if both eyes were equal, the fraction would be equal to 1. And if the fraction is greater than 1, that's an increase in degree of proptosis. So 1.3 is more proptotic than 1.1. And what he did was to look at that index in a postoperative period. You can see that the proptosis declines over time. So we looked at the proptosis index in our patients preoperatively, early post-op, and then greater than 6 months. And you can see that the swelling goes down, the eye comes back to a more normal position. Some of the technical things, I use a combination of thin and thick mesh for reconstructing the defects. You can see here's the hole in the bone where the tumor was because we removed all of this hyperostotic bone. And these are the CT scan results of the subsequent reconstruction. Here's the case report of the ocular constriction by the reconstruction right there is a med-port implanting, pinching on the lateral rectus muscle on the right-hand side. So when the patient tried to look over to the left, the lateral rectus muscle was tethered, so she couldn't do it. So we had the ophthalmic surgeon to take her back with a conjunctival incision and release the muscle so that her gaze was unaffected. So this case was the reason for the intraoperative force reduction testing to make sure we don't have that happen. And this is the reason why you need to remove the bone. This is Bill Caldwell again. Similar result, taking out all the bone, having a defect. And in this patient, the tumor recurred in the bone, not as soft tissue recurrence. So when you see that fuzzy bone, that means there's tumor in there, and you have to remove it in order to, ensure complete tumor control. So typical presentation is female patient, painless eye bulging, lid swelling, temporal fullness. We use a combined procedure with neurosurgery and ophthalmology. Take the bone out first, intradural tumor second, reconstruct the orbit, and then do the force reduction test to make sure the muscle's not restricted. Cosmetic results are excellent. Most often we get a subtotal removal, and the recurrence risk is greater than 25% long term. And we will use external beam radiotherapy for subtotal resection early on at about 3 to 6 months, rather than waiting for the tumor to recur. So let me see, it is, I've got 10 minutes left. I'm feeling better. I'm trying. And I just don't want to go too far. I want to show you, skip that part. Oh, this is important. In meningiomas, there's grades 1, 2, and 3. Grade 2 is atypical. It's kind of halfway between. We actually surgeons really don't know what that means anymore because the grading system has changed 3 times in 15 years. Now, the biology of tumors hasn't changed 3 times in 15 years, but atypical meningiomas have gone from an incidence of like 8 to 10% all the way up to like 35, 42% in some clinical series. So, and we don't know what to do with these if they're subtotally resected because the quality of the information about what to do with grade 2s is lacking, or was lacking until just very recently. So here's an example of a 30-year-old woman, attorney, many years of common migraine. She presented with, one of the worst headaches of her life, crescendo increasing headache, no loss of consciousness, but taken to the ER. And this is her CT scan. So, Jeff, oral boards, what are you thinking about? 30-year-old.
I'm thinking, why am I taking the oral boards again?
I'm picking on you.
Yeah, you're going to be
Come on, you can do it. You can do it.
years now.
So, 30-year-old sudden, worst headache, terrible.
Yeah, so
nausea, vomiting,
ruptured.
something, correct, a vascular.
Well, I would say if the answer I expect from my residents is AVM, 30-year-old temporal,
Yeah.
CTA. Yes, any unit, okay, they're all nodding their head.
They all agree.
So would that be sufficient for you to take the patient to the OR with?
This
Patient's
doesn't.
awake, she's a little drowsy, but she's falling.
I think that is she's drowsy.
Well, she's eyes open, voice, communicates. No hemiparesis.
I'd probably
she's got
get
a field defect.
If it's possible, if there's time, I'd get an angiogram.
So would I. This patient didn't. She was managed elsewhere, but they took her to the OR.
There is something little fishy going on in this sphenoid wing. You can see that. So
this turned out to be hemorrhage from in the brain adjacent to a meningioma, which turned out to be an atypical meningioma. Now, she had postoperative imaging that didn't show any residual soft tissue component. And the hematoma, there was no AVM. By the CTA, there was no aneurysm. She never had a formal angiogram. But now she comes wanting to know. She's all set up for radiotherapy. And the difficulty is targeting. because you didn't really have you didn't have an MR pre-op. You don't know where the base of the attachment of the tumor was. You can kind of see it on the CTA that it's kind of here, and there's some calcification, and it's unusual. Here's the information about atypicals, which is all recent. There's like 5 papers in this since April, and the last one's the most important. But this was a study from Northwestern in February, looking at National Cancer Database and looking at 7,800 grade 2 meningiomas, factors associated with improved survival, gross total resection, take out more, and adjuvant radiotherapy. So most neurosurgeons, including me, if we completely remove, now gross total, if you removed all the tumor coagulated attachment, I would observe those patients, but now I can't anymore. Here's another, this is the paper from our group looking at the relationship between size and likelihood of atypia, 1,100 patients, risk factors for grade 2, male sex, bigger tumor, vault location. Histologic features predictive of local control in atypical meningiomas, and we kind of use this labeling index cutoff of 7% to indicate whether the tumor is going to behave more aggressively versus not, and whether or not they had brain or bone invasion also predicted poor local control. This is, I think, a European paper, yes, Belgium. This is a prospective study, non-randomized. They were only able to collect 56 patients, but their findings were that early postoperative radiotherapy led to very good local control at 3 years. And then this is the important paper from the RTOG group, published in the Journal of Neurosurgery in July. And this is the first, this is class 2 data. This is the first prospective study of intermediate risk meningiomas. That means any grade 2 meningioma, regardless of the extent of resection, or a recurrent grade 1 meningioma, regardless of the extent of resection. Primary endpoint was 3-year progression-free survival. Small number of patients, but the 3-year progression-free survival was 94%. Adverse radiation effects were extremely unlikely. So, and it's important to note that in the Mayo Clinic series recently published for radiosurgery for the treatment of benign skull-based tumors, that means acoustic neuromas, meningiomas, glossopharyngeals, pituitary adenomas, the likelihood of a secondary tumor at 5, 10, and 15 years was 0, 0, and 0. Okay, so the likelihood that radiation is going to cause a different kind of brain tumor is very low. The likelihood of malignant degeneration, similar to the Sheffield data, is 0.2% at 20 years post-treatment. So very low risk. So because of this paper, primarily, I have to send, or not I have to, I have changed my practice, should be medically evidence-based. So I have to send all the patients to radiation oncology for a consult about the risk-benefit ratio of radiation therapy versus simple observation. So I got 1 minute, and I'm going to end here with some stuff. I'm going to check this out. This is interesting. This is the likelihood of systemic metastases in patients with second-time recurrence of atypical or malignant meningioma. So they have their operation, radiation therapy recurs the first time, you operate or whatever. When it comes back the second time, the likelihood of lung, liver, bone metastases systemically is 35%. So here, this is a thoracic mediastinal metastasis from an atypical meningioma in a patient with second-time recurrence, and this was the tumor that was fatal, not her intracranial disease. So we reviewed, the number of patients that came through the clinic, over 1,200. Median follow-up was 4 years, and then this is the demographics. Here's an example of a patient with biopsy-proven multiple hepatic metastases from his third-time recurrent atypical meningioma. He died from his metastases, not from his primary tumor. Just going to skip to the bottom line here, which is the likelihood of metastases in the screen patients was right here, 35%. We found one patient with a primary lung tumor picked up on the PET scanning. And so that is our new approach. If the patient has a second-time recurrence, we'll actually do a DOTA, which is amino acid PET scan, to make sure they don't have systemic metastases before we proceed with other treatment for their intracranial recurrence. And I'll tell you the reason that if you look at the complication profile associated with the first reoperation, it's 32%. The second reoperation, complication rate is 62%. The third reoperation, there's only a few people, it's 70%. And for the fourth reoperation, it's like 72%. In the first reoperation group, the complications of 34%, 80% of those patients required another operation to fix the complication. Right, so, operate carries some risk. And so if you have a recurrence that's small, doesn't really need surgery, the patient might be better off with radiotherapy than another operation. So I'm going to close with a few things for the residents, and I'm done. Meningioma surgery is still very complex and it's humbling. Nothing is ever a chip shot. There's one surgeon always used to use that term, which the residents would say, I'd say, don't ever say that. You can do a sural nerve biopsy, get a strep infection, the patient lose their leg. And you can do meningioma surgery and have a bad outcome. So you always should do your best. You should get your help when you need it. I've published papers on complications where myself or my resident has cut the vertebral artery on a retrosigmoid operation. Twice it's happened to me. Nectatic vertebral turn the patient's head, the artery just comes out more. And, call the vascular surgeon, the resident's not, or cut the spear sagittal sinus longitudinally with a bone flap. And the resident's not capable of, they don't know what to do. I call the vascular surgeon, fixed it, no problem. Never had a terrible outcome from a vascular injury when I've called my colleague, and we've sorted out, we've published it. What to, you cut the vertebral artery, put your finger on it. Do not put hemostats and stuff that will damage the vessel wall. And he was able to repair it. Told the patient did fine, brought him back 8 weeks later, took his tumor out. You should always be honest with the patient and families. Learn from your mistakes. As Dr. Wilson once told me, Michael, it's okay to make a mistake, but it's not okay to repeat it. So you should, if you do something and have an adverse event, you shouldn't do the same thing again. And you can also learn from when things go well. If you get a good result because you used a slightly different technique, you should probably switch your technique. So these are some things I found, quotes from Winston Churchill, which I thought are very relevant to neurosurgery residents. Continuous effort, not strength or intelligence, is the key to unlocking our potential. So if you want to do well in your training, you've got to work hard. It's not going to come to you by osmosis. Success consists of going from failure to failure without loss of enthusiasm. That's neurosurgery in every subspecialty. It might not work out all the time, but you're doing your best. You did the right thing. Some of these things are unpredictable, but I remember once when somebody cut the innominate artery doing a trach at St. Mike's Hospital. The residents were talking about Alan Hudson last night. And Alan, anyways, got that solved, and the junior resident, Alan, put up the next set of films, big parasagittal meningioma, and Hudson said to the junior resident, call me when the tumor's out. And I was like, whoa. I mean, talk about getting right back into the saddle. Cut somebody's innominate artery, we had to split their sternum, get the vascular surgeon, they're all like, oh. It was a badly disabled subarachnoid patient, we were doing our own trach. But here the resident cut the aorta, and we fixed it, and then the attendings put him right back into the saddle and said, take this tumor out home. This one, I like this one. If you're going through hell, keep going. And then this is when all your buddies in tech are doing everything, and they got a house, and they're married, and they have kids, and, you know, keep your blinders on, because you're doing good work, and we make a living by what we get, but we make a life by what we give, and I think it's a good specialty, and it's been a lot of fun. And I'll just end with that. That's my wife, my 2 boys, and as you know, I have other interests, and it's been a lot of fun. I hope you enjoy it as well. Thank you.